Hey everyone, welcome back to my channel. So this video is based on a specific request, and let me tell you guys that ovarian tumors came up a lot on my test. So this is a relatively high yield topic, and there's also a lot of UWorld questions on that. So today I'm gonna go through about 4 UWorld questions with you about ovarian tumors and break them down, show you exactly how to approach them, and hopefully after this video this topic should not confuse you anymore. Alright, so the first question, like I always do with the questions with you guys, like I always approach it, the first thing you should do is to read the last couple of sentences, because these usually give away free information. So imaging studies reveal a right-sided ovarian mass and an accumulation of free peritoneal fluid. Her blood work shows a marked elevation of CA-125. You see, guys, you see what I tell you about the last 2 lines? It essentially gives away everything. Oh my god. So before I even read the whole vignette, I know that this is a case of ovarian cancer. It can save you a lot of time on the test when you are in the middle of a block. The block actually shows you a mix of all systems and topics you can ever imagine. So once you find out where you are, this is kind of reassuring. So now we know this lady has ovarian cancer, but we don't know which type. We don't know like what exactly. We just know this is ovarian cancer, right? Now, if you haven't already figured out, guys, CA-125 is a marker for epithelial ovarian cancer. Okay. Now, remember, guys, that ovarian tumors are classified into epithelial tumors that come out of the surface epithelium. There is germ cell tumors coming out of the egg, and there is also sex cord stromal tumors coming out of the follicle and the cortex, like the granulosa cells, theca cells, and fibroblasts in the cortex. So I'm gonna dive into this later, but I just want you to understand that CA-125 is associated with epithelial ovarian tumors. Okay, so let's read the vignette together. A 60-year-old woman, so she's obviously postmenopausal, gravida 1 para 1. Okay, so she only had 1 child, comes to the office with abdominal distension and decreased appetite. Guys, we've already seen here, imaging reveals a right-sided ovarian mass and accumulation of free peritoneal fluid. You gotta understand that ovarian cancer metastasizes to the peritoneum, which is probably why she has abdominal distension and decreased appetite. And I'm gonna show you a picture in the next question about how peritoneal metastasis can lead to this picture. She also has lost 10 pounds unintentionally over the past few months. Right away, whenever I see unintentional rapid weight loss over only a few months, I should be suspicious. She takes no medications, and especially in an elderly woman. She takes no medications and has received all recommended vaccinations except for the HPV. The patient's mother had BRCA positive ovarian cancer and died at the age of 55. Now this shows us that she has a family history. BMI is 30. This is obese, but is obesity really a risk factor for ovarian cancer, or is it for breast cancer? Yeah, it's rather for breast cancer, so I'm not going to highlight that. And imaging revealed a right-sided ovarian mass. So the question or the examiner already knows that you've already figured out this is a case of ovarian cancer, but the question really says, which of the following most likely would have reduced the risk of this patient's condition? Reduce the risk means it's a protective factor. So obviously she has all the risk factors, and what we mean by risk factors would be factors that increase the risk of ovarian cancer, some of which she already had, and there is factors that are protective, okay? So factors that increase the risk include family history, BRCA1, BRCA2, or Lynch syndrome. All these you can see are genetic. So that's how I classified them. And then there are other factors related to the ovary. So the more you ovulate, the more the ovulation cycles, the more the damage and repair. So the more the damage and repair, the more the probability of genetic damage of the DNA and possible transformation or malignant transformation. And so these conditions mentioned here, infertility, nulliparity, PCOS, or endometriosis, you can see here that these share one common theme in that there is damage in the ovary, okay? But with nulliparity, for example, it's because she did not get pregnant at all, means that she's always ovulating every cycle, okay? So that means nothing has stopped ovulation, or there is no pregnancy to stop it. So every month she's ovulating, and ovulation means there's always damage and repair, and that is obviously associated with a high risk of malignant transformation. With endometriosis, there's also damage. With PCOS, there is a lot of cysts in the ovary, okay? Now regarding the protective factors, which the question is asking about, so anything that is the opposite of this will obviously be protective. So the less the ovulation cycles, the more the protection, right? Or the less the ovulation cycles, the less the damage to the ovaries, and therefore less risk of malignant transformation, or because of less DNA damage. So oral contraceptive pills means she's not gonna ovulate this month. The combined ones, estrogen, progesterone, prevent ovulation. So obviously that's the opposite of this. For example, multiparity, same idea. A pregnancy gives a break to the ovaries, in other words. Breastfeeding, same idea. Remember that breastfeeding women do not get pregnant because of prolactin. And salpingo or oophorectomy, obviously if she removed the entire thing, where is cancer gonna come? So yeah, which of these protective factors do you think is in our patient? So the question is asking which of the following most likely would have reduced the risk of this patient's condition. Now, obviously, she has a lot of risk factors we've just seen, like BRCA positive, and she's old, I guess. Para 1, she only has one child. It's still not enough, I guess. I think this is probably a risk factor. So now that we figured out she has ovarian cancer, the question is asking about a protective factor. So which of these do you think is a protective factor? I would say use oral contraceptive pills. Like I said, these prevent ovulation, so there is less cycles, less ovulatory cycles, therefore less damage to the ovaries, okay? Less damage, less repair, therefore less risk of genetic damage while repairing, less risk of mutations while repairing. Okay, remember her cancer is in here in the surface epithelium. Now, consistent condom use would be a protective factor for cervical cancer. Actually, this is a very bad distractor because it's mentioned here she takes no medication. She's received all vaccines except for HPV. So the examiner here is because, like, in case someone picks up on this, which is also a distraction, here you go. If you have this answer choice, but they're all wrong because it doesn't go, like, they don't go together, especially that imaging shows an ovarian mass. Okay, so he already gave away that it's cancer, ovarian cancer, not cervical cancer. Long-term antioxidant supplementation, it's actually not a protective factor for any type of cancer, let me tell you. Nulliparity is indeed a risk factor rather than a protective factor. So the correct answer is D. All right, moving on to the next question, and this will consolidate the information even more because it's also about surface epithelial tumors. So let's see. A 73-year-old woman, obviously she's postmenopausal, gravida 0, para 0. Now that is the full-blown risk factor, nulliparity. Comes to the office due to breathing difficulty and increasing abdominal girth. Now, what is breathing difficulty? Remember, guys, epithelial ovarian tumors spread to serous cavities in general. It's not just the peritoneum where she has increased abdominal girth, but also the pleura. Okay, so that is probably why she has breathing difficulty. She also has decreased appetite and constipation. This is another indication of spread or metastasis to the peritoneum. I'm going to show you a picture in a moment. Decreased appetite, constipation that has worsened progressively for the last 6 months. Something, guys, that I learned in clinical is that whenever you see something within months, it's most likely malignant. Within years, it's most likely benign. Within days or weeks, it's most likely acute inflammatory. So within months, something happening like that, it's in an elderly woman who is nulliparous, is suspicious, right? The patient has no other medical conditions and has not seen a healthcare provider in several years. On physical exam, the abdomen is distended and non-tender, again confirming this, and non-tender with right adnexal fullness, right? Guys, adnexal means something related to the ovaries, okay? Right adnexal fullness means she has a right ovarian mass. Just interpret it like that and get it over with. She undergoes laparoscopic surgical evaluation for a right adnexal mass. So it already gave away the answer. Microscopic examination of the surgical biopsy specimen reveals what you see in this picture, anaplasia of epithelial cells. If you look at these cells, they display the malignant criteria or criteria of malignancy, where the cells are, the nuclei are hyperchromatic and they do not resemble any tissue. That is why they're anaplastic. They're as if undifferentiated. With invasion into the stroma, as you can see, the cells are not within the basement membrane. You have a lot of cells inside the stroma here, so they're not maintained within the basement membrane, which means it is malignant. It's not a serous cystadenoma, rather it's cystadenocarcinoma. And multiple papillary formations, this whole thing, and then this whole thing, and then this whole thing, these are called papillae, okay, with a fibrovascular core. This has the vessels that support the tumor. Which of the following is most likely to be elevated in this patient? Now, once you see this picture, you should obviously know the microscopic picture of serous cystadenocarcinoma, but even if you don't, and you know that, look at the you look at the demographics and the picture of metastasis to the peritoneum, you should figure out that this is an ovarian cancer. Okay, but again, it's not enough for you to figure out it's an ovarian cancer, because you gotta know that it's an epithelial one, and you would know it's an epithelial one from the picture. So epithelial ovarian cancers show increased CA125, which is I don't know what it stands for. CA125 is a marker of epithelial cells of the ovary and fallopian tube, but it is not found in other types of ovarian cancer. So alpha-fetoprotein, for instance, is found in yolk sac tumors, okay? Beta-HCG in choriocarcinoma, and estrogen in granulosa cell tumors. So you gotta figure out that it is epithelial tumor. Okay, so let me tell you guys why she has abdominal distension and constipation and all these stuff. Obviously, because the ovarian cancers spread to the peritoneum, and they also spread to the pleura, which is why she has breathing difficulty. Now, because they spread to the peritoneum, and the bowel is covered by peritoneum, she is gonna have problems like constipation and also increased abdominal girth. Okay. Now, like I told you guys, here are the 3 types of ovarian tumors. Only the epithelial one is associated with CA125, all right? So these are called surface epithelial tumors, including the serous cystadenocarcinoma we just saw. And there's the benign form of it, which is the serous cystadenoma. Now, there is something called germ cell tumors. If you look at this follicle, you have the germ is the egg, okay? So from germ cell tumors, what can possibly come out? You have dysgerminomas or extraembryonic tissue like yolk sac tumors or a teratoma. That's what can come out of the egg. So either the germ cell or dysgerminoma or extraembryonic tissue, or somatic, which is the teratoma. And the sex cord stromal tumors, remember guys, embryologically, sex cord stroma gave the theca and granulosa cells in females, and they also gave sertoli and Leydig cells in males. So these cells, granulosa cells that surround the ovaries, and the theca cells are called sex cord stroma. And also the stroma here, the fibroblasts, are also considered part of the sex cord stroma. So if you have a fibroma, a granulosa cell tumor, a thecoma, all are considered sex cord stromal tumors. But the most common, obviously, are the surface epithelial, and that's the one we were talking about. Now let's move on to other types. Okay. A 49-year-old woman, gravida 2 para 2. Look at the demographic. She is not nulliparous, so this risk factor is out of the calculation. Okay, comes to the office due to 10 months of irregular vaginal bleeding. Now that is suspicious. Her last menstrual period was 3 years ago. Now, what is the point of this? What is the point of saying this? The point of saying this is to tell you that she's postmenopausal. She hasn't had a menstrual period for 3 years, means she is a postmenopausal woman. And the tumor we're about to talk about obviously should be more common in postmenopausal women. So that's what the question wants you to know. Every piece of information matters, guys. And she has irregular vaginal bleeding, so it is not normal, obviously. It's unusual for a postmenopausal woman to have 10 months of vaginal bleeding. Right away, you should suspect something. She has a history of hypothyroidism, takes levothyroxine. This is a distractor, guys. Don't note this, okay? Ultrasound reveals a thickened endometrium. Wow. And a solid left adnexal mass. Now, this woman has endometrial thickening, and at the same time, she has an ovarian tumor, which means that there is something that this ovarian tumor is producing that leads to endometrial thickening. And the only thing I can think about that leads to endometrial thickening, if you remember from physiology, would be estrogen. But I'm not going to jump to conclusions now. But you can already reach the diagnosis if you stop here. But, well, let's continue. Endometrial biopsy is abnormal, which means there's some sort of dysplasia. So it's not just endometrial thickening, rather it moved like to malignant transformation. So up to that point, and the patient requires surgery. Intraoperatively, the ovarian mass is yellow and firm. Now, what do we mean by yellow and firm? Remember, guys, I told you that the sex cord stromal tumors have the thecoma and the granulosa, right? Now, yellow means it has a lot of lipid, and theca cells have a lot of lipid, and that's why they appear yellow. Usually, when granulosa cells cell tumors form, they also have theca cells with them, which is why they appear like that. Pathology reports small cuboidal cells in sheets, like you can see here in front of you, with gland-like structures containing acidophilic material like this. This is called Call-Exner bodies, guys. Cells are arranged in a microfollicular pattern around a pink eosinophilic center. This is what we call Call-Exner bodies, and that's quite specific to granulosa cell tumors. Now, guys, even if you can't figure out the picture, like obviously this picture I brought it from like first aid, but the question didn't show a picture, so you might be reading this like, oh my god, what is that, and like you don't know the histologic picture. But there is another way to solve this question. Once you remember physiology and you remember that the only hormone that leads to endometrial thickening is estrogen, then you can very easily solve this question. Which of the following is most likely secreted by this patient's tumor? So the question already gave away that this lady has a mass in her ovaries. So she has an ovarian tumor, and this ovarian tumor is producing something that led to endometrial thickening, and not just thickening, but up to the point of abnormal endometrial biopsy. So it might be endometrial cancer, right? So once you figure out that what estrogen leads to endometrial thickening, you can already answer the question that estrogen is the hormone secreted by this patient's tumor, right? Okay, so again, this is a sex cord stromal tumor, and the granulosa cells, we all know, produce estrogen, right? But don't forget that they might have some theca cells with them, which is why it might appear yellow. All right, moving on to the last question. A 26-year-old woman, gravida 1 para 1, comes to the office for a routine examination. Nothing wrong here. She noticed new facial hair over the past few months and thinks her voice is deeper. So these are signs of virilization. Now, at this point, I don't know what's going on, because it could be PCOS, it could be something else, right? But her last menstrual period was 5 months ago. Now, guys, there is something wrong here, right? Because she obviously is 26, pretty young. So her last menstrual period 5 months ago means there is something wrong here. Why isn't she getting her periods? Okay, so that is amenorrhea, alongside a deep voice, is concerning for virilization. So there is androgens around, okay? The patient's mother died from invasive lobular breast carcinoma at age 60. Now, I will not consider this family history of breast cancer, no, I will, but at age 60, doesn't really say that there is a strong family history. Like, it might be a sporadic case. If it was like at age 50, 45, something like that, I would have been concerned. Physical exam is significant for, so this is a distractor, okay? Physical exam is significant for coarse facial hair, and pelvic exam reveals clitoromegaly with a large adnexal mass. Okay, so it already gave away that the problem is in the ovaries. Now, at this point, you guys might think that it's PCOS, right? But it is one mass. That's number one. PCOS usually shows multiple cysts, okay? Now, urine pregnancy is negative, so her amenorrhea is not because she's pregnant, it's because of something else. Pelvic ultrasound confirms a large ovarian cyst. So it's one single mass, guys. It's not PCOS. It's one single mass. And so it must be an ovarian tumor that's producing androgens. And these androgens are causing her amenorrhea. These androgens are also causing her voice to be deeper. And these androgens are also causing her facial hair and clitoromegaly. So which ovarian tumor produces androgens? Like I told you guys earlier, that we have sex cord trauma, and this gives granulosa and theca cells in females, which produce estrogens. So this is out of the equation, obviously. And sex cord trauma gives sertoli and Leydig cells in males, and these produce androgens. This is probably the only possible correct answer, sertoli-Leydig, because as you can see, this germinoma is a germ cell tumor. It doesn't produce anything actually. Mature cystic teratoma is a somatic form of germ cell tumors. This one doesn't produce androgens, rather LDH. Serous cystadenocarcinoma, just CA125, no hormones. So the only correct answer is a sertoli-Leydig. It's actually very rare, but usually happens in young women, and it does produce androgens. That's probably what's leading to her virilization. All right, guys, I hope this makes sense, and let me know what you think in the comments.